Welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion. Hello, everyone, and welcome to what we are calling Season 2 of the Surgical Assistant Podcast 2026. We're kicking off a new season, and we have thoroughly enjoyed doing last year. I'm Kelly, and with me today, as usual, is John. How are you, John?
Hey, Kelly, I'm good. Nice to see you.
Good, you too. So we're excited. We decided to kick off this season with a series that we've been talking about for quite a while about hernias. So we're in this series of we really don't know how many episodes it's going to be. We think that it's going to be at least 3, probably up to 5 or 6, depending on how many types of hernias and how niche we get with the hernias. But we're going to do a hernia series and dedicate each episode to a specific kind of hernia. We're kicking this one off today with the inguinal hernia, which is it's one of the most common robotic surgeries we do, and open too, but robotically, I would say it's one of the most common robotic procedures. Would you agree?
Oh, definitely. I think there's I think 1 million hernia repairs a year in this country.
Mm-hmm. Yeah. So we wanted to also just kick off the series in general with talking about what a hernia is in general. And most of us are going to know the answer to this. We should. If you're listening and you're not a first assistant or you're a brand new first assistant, we can talk about what a hernia is. And it's generally a weakness in the abdominal wall. A portion of today's inguinal hernia is a weakness in the processus vaginalis or the posterior abdominal wall, depending on if it's a direct or indirect. And we're going to get into all that in just a few minutes. But it's a weakness in a muscle layer that allows organs that are on the inside to protrude through structures the weakness and push out. And this can cause pain, discomfort, and in severe cases can cause intestine to get trapped. Colon or small bowel to get trapped and cause herniation, and that can be detrimental, as we all know. So that's, in general, what a hernia is. Do you have anything to add to that, John?
No, I think that's a great basic definition. People want to limit it to like an inguinal hernia or umbilical hernia, but not really. I mean, exactly what you said. It's when an internal organ pushes through its connective tissue into another space, because you can herniate your brain into your brainstem because it goes through the foramen magnum. People talk about herniation all the time of different things. You have a disc herniation, you have that. So that's a perfect definition, I think. But I think since we're starting off with hernias, I always like to start off with a quote by Henri Fouchot, who was a French anatomist and surgeon in the beginning part of this century, in the 20th century anyways. And his quote was, "A healthy man is, unknown to himself, a bearer of hernias." So I just like to write that on the wall. So, every grease board has it. I write it because I think it's true. I mean, everybody is a bearer of hernias. We just don't know it until it happens. But our body is set up in certain ways where there's naturally anatomic weak spots. So that's all I got to say on that.
It makes me think of those, and we'll get into this later in the series, I'm sure, is the hiatal hernia is a good example. It's just
exactly
right. And so a hernia it's a herniation, can happen anywhere in the body. And of course, in this series, we're talking typically in the general surgery realm, mostly. So, but so the inguinal hernia, I talk about the inguinal area of where this happens, and anatomically, it's Hasselbeck's triangle. Down there is the area where these occur, the weakness in the posterior wall, or when the processus vaginalis doesn't close completely. So we know the processus vaginalis in a male is where that spermatic cord and the testes drop down through that. And typically that's supposed to close up, right? That area. And in the females, it's the round ligament. And so when that in embryologic development, that is supposed to close up. And so sometimes it doesn't close. So area. And we're going to talk about how we can differentiate between direct and indirect in just a second. You had a really good tip on those as well. Do you have anything to add there, John, with the inguinal hernia presentation specifically? Did I cover that pretty good before we get too far into the weeds?
No, I think you did, because that's the key, is we can get so far into the weeds on this. I mean, your body gets a signal to either be male or female. And if you're male, then the testes move down through that canal and end up in the scrotum. And whether that processus vaginalis closes or not is whether you have an indirect inguinal hernia, which is
Right.
congenital, or you can have an acquired hernia, which is a direct, which is exactly what you said is perfect. And then
Right.
one thing early on in my career and for most of my career, I was always confused by the difference between direct and indirect because that Hesselbeck's triangle always screwed me up because I really
Mhm.
didn't understand the anatomy of it and how it worked. Now, after being an assistant for years, go ahead, what were you going to say?
But John, I do wanna just along where you said it confused you for years, I
Hmm.
asked early in my FA career, I think I was about 3 years in, I asked a veteran surgeon, we were doing an open repair, and
Hmm.
I had been studying the anatomy, really trying to understand it, and I just was transparent with him during the surgery and said, "I am so confused about this anatomy down here, like, I
Yeah.
cannot keep it straight," and he told me, he said, "This is some of the most difficult anatomy to learn." He said,
Mm.
I have never known a surgeon that has not struggled with the anatomy in this area. Just because when you're coming and we'll talk in a few minutes, but I just wanted to
Hmm.
reiterate
Oh,
about when we're
yeah.
coming down externally through those layers, they're just so subtle. There's so many layers to identify
Hmm.
muscles and fascias, and it is some of the most difficult anatomy. So I want to encourage our listener if you're confused, like John said, he was had a hard time remembering the indirect and direct and how to keep them apart, and he's gonna give you a real cool
Hmm.
tip here in just a second that I had never heard. I finally just trained my brain how to remember which one was direct and indirect and what anatomy we were dealing with, but he has a cool tip for you.
Yeah, and I'm going to tell you that tip in just a second. But in regards to what you just said, that's exactly right. Because when I was studied up doing research for this episode on a basic level, but there was stuff I never even knew, like what's it called? Bogros space. I never heard of that.
Right.
And that's like a potential space in between the transversalis fascia and between the peritoneum and the posterior transversal. I'm like,
Right.
okay,
Just
whatever. That's just like,
yeah.
that's the minutia that I don't need to know. We don't need to know as a first assistant. But
Right.
yeah, because I was so confused early on, there was somebody told me of a mnemonic that's an easy way to remember where they are. Basically, it's MDs don't lie. So when it comes to inguinal hernias, it's inguinal hernias are above the inguinal ligament. The M for MD is medial to the epigastric vessels is a direct hernia. Okay. And that occurs within Hesselbeck's triangle, and it's more common in older adults because it's acquired hernia. And then you have the lie part, MDs don't lie. It's lateral to the epigastric vessels is an indirect hernia. And that occurs when you have the deep and superficial inguinal ring. And that's when it basically the hernia follows the spermatic cord. That's congenital typically. Then you have hernias below the inguinal ligament, which are femoral, and femoral to me, that's the abbreviation is more common in females than in men. So, I mean, that's a down and dirty quick. It doesn't go really into too much depth, but it's a good way to keep it ordered in your brain. Medial to the
Mhm.
epigastric vessels, lateral to the epigastric vessels, below the inguinal ligament is
Right.
a femoral.
So all
So,
of those are considered inguinal hernias. They're just
mhm,
specified into exactly where that herniation is occurring, and we are more familiar with direct or indirect. The repair is
mhm,
gonna be the same. It's not really going to affect the, uh, especially from the end if we're doing a laparoscopic robotic assisted repair, it's not going to affect how we're doing that repair. But just knowing your anatomy, we're gonna talk here in a few minutes too about the some critical anatomical landmarks and structures that we need to know down there and that our surgeons are concerned with too. So we always wanna know our surgeon's perspective and what they're, looking at and thinking of when they're doing these surgeries.
mhm,
One thing I do wanna talk about, John, is in
mhm,
mentioning is as the first assistant, we do wanna know kind of just a generalization of how these present to the office. We've already talked
mhm,
about these patients coming in with groin pain, possibly a bulge. So they're complaining of this is either a sudden onset or they've had it for
mhm,
years and now it's starting to bother them with picking up, straining, any different activities that can make this worse. And so then the surgeon starts thinking about surgical repair being indicated.
mhm,
So, one of the things, since we know that hernias are commonly recurrent, that we know that once a hernia is fixed, a common problem is recurrence of that hernia. So, one of the big questions we want to find out from the patient or the surgeon wants to find out is, have you had it fixed before? Has it been repaired before? And that's where we come in, whereas if they say, yeah, I got it fixed when I was younger, they did an open repair. Well, we know that this time we're not going to do another open repair. We're going to go to the opposite and do a laparoscopic repair, and vice versa. If they've had it fixed laparoscopically in the past, then we're going to fix it open. Just kind of flip-flopping back and forth. That just gives you an
Mhm.
idea of what the surgeon is considering. Of course, as with anything, when we're looking at that patient history and knowing what the risk factors are for infection, same thing. We're putting a foreign object, essentially, even if
Mhm.
we're we're putting an implant in a patient and mesh. We know the problems. You just look at the lawyer commercials on TV,
Mhm.
mesh lawsuits and stuff. We are concerned with that infection rate. We're concerned about recurrence with the hernias. And so,
Mhm.
looking at those patient factors, smoking, diabetes, all the things that increase their risk for all these things. Just something to know.
Mhm.
Just something for us to know, and kind of looking at, and something to know that the surgeon is considering in the type of repair that he's doing, in the type of mesh that he's using. So
Mhm.
we just want you as a first assistant to kind of be thinking along the lines that the surgeon is. Like when you see a surgeon using a certain type of mesh routinely, and then all of a sudden for a certain patient, he's using a different kind of mesh. These are the things that makes him make these decisions,
Mhm.
the patient's comorbidities and their history and all these things. So
Mhm.
it's good for you to know as the first assistant what the patient's history is. Know as much as you can, as we've said before in other
And
in episodes. Know as much as you can about the patient.
that's
Um,
key.
so uh, before we go on to the crucial anatomical landmarks, do you have anything to add to that, John? As far as the
Yes, I would like to I mean, this is the first in a series, so I always think it's good to start at the beginning, and I always like to know the history of surgery and kind of where we came from. We did that episode on the history of surgery. I love history, but just basic down and dirty, I consider hernia surgery to be broken up into three major areas. There's like antiquity to the 1700s, basically, where there wasn't a lot of advancement. They used to just chop off the testicle and cauterize that and let it heal by second intention. And of course, their outcomes were horrible, a lot of pain, infection,
Mhm.
reoccurrences. Then you have like the 1700s and 1800s where like all the names that we're familiar of in surgery, like Scarpus, Campers, who else? There's Hesselbeck, Cooper's ligament, all those
Mhm.
people, they started doing more cadaveric dissections and they noticed the anatomy, it got more involved in it, which then led to the 17 and 1800s when people like Bassini were around, and it led them to maybe dissect out the sac more, ligate the sac high, and close it. And then they had antisepsis now, so people weren't getting infected and they had much better outcomes. But then Bassini came along and he did his tension-free repair, a tissue-only tension-free repair, and he was getting great results from that. And then I consider in the 80s when Lichtenstein came along applying the mesh to that, then that's when hernia, in my opinion, hernia surgery really took off. I mean, you have it with Schuldeis, and I don't want to get too far afield right now, but Schuldeis was a Canadian surgeon. He had a hernia institute, and he did his Schuldeis repair, which you don't see too much anymore. And that's basically just imbricating the floor and reinforcing it with suture only, which in the initial Schuldeis repair, though, historic fact or fun fact or trivia, whatever you want to call it, his initial repair was done with stainless steel wire because he wanted a monofilament, something that wouldn't get infected, but that would last a long time because I guess it was before Prolene. When you really think about it, there was only a couple of types of suture back then. It was plain gut, chromic gut, silk, and then wire. And they had 3.0 and 4.0 surgical steel wire that they used. So that's what he would use for his repair. Anyways, but it's not done too many times anymore. And then Lichtenstein came along, added the mesh to it, and he was a tension-free repair like Bassini's principles. And our hernia recurrence rate has gone down considerably and the outcomes have improved much more. So that's just kind of all I really wanted to bring up was the
Right.
history of
Thank
it.
Yeah, thanks, John. I love that the little quick history of the evolution of that. And
Mhm.
you just mentioned there at the very last, the key is the tension-free repair. I mean, that's where they
Oh,
found,
yeah.
okay, this is what we need. We don't need tension on this. So better results and a better repair
Mhm.
when there's not any tension on it. So I think that's key there as well. And we
Mhm.
can, when we're looking at these really what I call my landmarks and landmines, the
Mm.
anatomical structures down here. What do we have in this area? We have lots of nerves. We have
Oh,
lots of
yes.
vasculature that we want to
Mhm.
know where these things are. And as surgical residents, the surgical residents are learning about these things called the triangle of pain and the triangle of doom. And they're called this for, you can kind of surmise just by the name that the triangle of pain is if you get into this, the structures in this area, the patient's going to be more prone to have chronic groin or inguinal pain because of the nerves that are located there. So we're going to talk about that triangle of pain first. And superiorly in this triangle, which you visualize a literal triangle to the portion of this, is the iliopubic tract. Medially, the spermatic vessels, and inferiorly, the peritoneal reflection. So,
Right.
we know that peritoneal reflection is down there in the pelvis, coming around. The bladder is close by. I don't want to forget about the bladder being close by. And incidentally, I'm going to mention there that sometimes we do want to place a Foley catheter and get that bladder drained. Some surgeons want a Foley placed with any inguinal hernia repair. Some surgeons want it replaced only if you're doing bilateral hernias. Know what your surgeon likes, but also know that that's something for you to ask. If you're not sure, ask, do they want a Foley catheter? Do they want the patient to void right immediately to surgery? Because we do want that bladder down and out of the way. So I thought that's worth mentioning there.
That's a great point.
So now this triangle of pain does contain nerves, and we're going to talk about just briefly. It's the lateral cutaneous nerve of the thigh, the femoral branch of the genitofemoral nerve, and the femoral nerve. Each of these causes chronic groin and inguinal pain. We want to avoid, or the surgeon wants to avoid, mesh fixation in this area, the triangle of pain. So it's called the triangle of pain because you're going to cause the patient pain. Chronic pain that they cannot get rid of if we go tacking mesh in this area, putting even suture. If you tie it down tight and you're in this triangle here, it's not going to be good for the patient. So something that our surgeons are learning when they're coming through residency and they're learning to do this is something they are questioned on in their boards. They need to know this. So as a first assistant, you kind of want to know what they're looking out for, right? Is that what you... I mean, just kind of, you're sitting there watching them. And we are talking specifically now, John, we're talking about that intraperitoneal approach, okay? Because we're not going to be in this area if we're coming from an open approach. And we'll talk more about that in a few minutes. But right now, I just do want to clarify to the listener that we are talking about that laparoscopic or robotic assisted intraperitoneal approach.
Exactly. Yeah, you have that tap approach or the TEP approach. But no, that's common. I mean, I think that's one thing I always look at, because the surgeon who's operating with a robot, it's like when you're driving, you're focused on what you're looking at. The passenger can see other threats that you might not use the word threat, but whatever that you might not see. In fact, I was doing a robotic inguinal hernia repair with a surgeon at the hospital I'm currently at a month ago, maybe. And I noticed off in the distance down in the pelvis, there was like a U-shaped adhesion. And just as we were out, I said, "Hey doc, do you think that's going to be a problem?" And he's like, "What?" And then I called his attention to it, and he's like, "Oh my God, yes." And then he went and took it down, and then he goes, "Thank you. You saved that patient from a possible reoperation."
That's a
And I
good...
was just, it's part of our job. Just like when Kelly mentioned the branch of the genitofemoral nerve and all the nerves that are in the triangle of pain, that's what we need to keep an eye out for, because he may be working at one area and dissecting and deciding maybe where he's going to put a stitch, and then he lays the mesh over that. And if he hears it with a stitch, maybe it's obscured, but if you can see it, just call it out. And I just tend to ask a question, "Doc, is that the femoral branch of the genitofemoral nerve or the lateral femoral cutaneous nerve?" Because you'll see that lateral femoral cutaneous nerve again when we do hip surgeries, but that's another episode. So I always talk about that. And then I've heard surgeons tell me in the past that when they come across, like in an open approach from the top down, they'll cut the ilioinguinal nerve, and they'd rather have the patient have numbness of the thigh and maybe, some of the testicle rather than pain.
Exactly.
A non-absorbable suture and entrap that nerve, they are miserable. That's why I've had surgeons say, "Well, I only use absorbable sutures here because if I do entrap the nerve, I want it to eventually dissolve." But they could still form a neuroma and still have chronic pain. So I think that's an important part, Kelly. That's very good that you brought that up. I mean, we're another set of eyes. We're not doing the operation, but, and this is where I just have to give a shout out to David Laurier. He's a robotic surgeon that I think he works in California, San Diego, if I'm not mistaken. But I found his videos on YouTube, and I'll put a link to them in the description. There's a lot of master classes on robotic inguinal hernia repairs, and it really opened my mind to the advancement that we've come. He's part of the International Hernia Collaborative, but the way he describes it, which is the way Frouchot described it, the myopectoneal orifice, which is basically just a potential space for a lot of hernias to occur. But the way he describes it, I mean, his recurrence rate is almost zero. I mean, because the way he does his dissections and everything, I just think it's a fantastic video, not only for anatomy and technique, but just overall his videos. He does them laparoscopically and robotically. He's exclusively robotic now, but he's fantastic. So Dave Poirier, a masterclass on inguinal hernias, you can find it on YouTube. I'll leave a link in the description, but that's why it's also important to leave fat over the nerves. You don't want to, at one point in the beginning of my career, they used to skeletonize the nerves because they thought it helped, but no, now they learn no, because they can actually get pain with the enlayment of mesh. So you never want to put mesh directly on nerve. So there's always should be some tissue between the nerve and the mesh. So but I think if I ever have to have an inguinal hernia repair, or if I have to give it's going to be robotic, because I think it's the best way to do it right now. I personally, initially I didn't think that. Thought, what a waste of freaking time. We could do it open in 20 minutes. And I did a ton of them in my early career, and they're great. But no, robotic repair, in my opinion, the way Lurie does it, that's the way I would have it done. It's phenomenal. So and that's where it's important for the first assistant to know your different types of mesh, where it goes, how it's fixated, should it be fixated or not? That's another controversy. But to know the steps of the procedure and how it's done correctly, because we're a second set of eyes for the surgeon to see something maybe he can't because he's looking at driving the boat.
And knowing the anatomy and the landmarks that the surgeon is looking out for as well. I mean, that is your responsibility as the first assistant to know these things. I mean, you're not going to know everything, but to know the general anatomy and, again, the general landmarks and critical structures that the surgeon is looking out for is, in my opinion, it's just integral to what we do. The triangle of doom is named because of the significant vascular structures that are here. So the triangle of doom is going to contain the external iliac artery and vein. It's inverted. It's an inverted V shape with the apex at the deep inguinal ring, so that the apex of the triangle is in that deep inguinal ring. We definitely want to avoid staples, tacks, and sutures here, and extensive dissection even. And if you notice in a robotic repair, the surgeons don't need to be digging way down in there, and they typically don't because of this. You get too far into the weeds anatomically there, and you're going to be getting into structures you don't want to get into. We don't need massive bleeding, and so thus it's called the triangle of doom, because obviously if you get into the iliac artery and vein, you're going to be having a problem. So medially, the vas deferens is here, laterally the gonadals, and inferiorly is the peritoneum again. So that's our borders for the triangle of doom. Another good landmarks to know are the anterior superior iliac spine, or ASIS, and the pubic symphysis. These are fixed landmarks for the surgeon to define the safe boundaries for trocar placement and dissection. So for trocar placement, they're looking at the ASIS. And for newer surgeons, they might want you to mark those. And really, veteran surgeons might go ahead and mark the ASIS and the pubis. I try to do that sometimes after draping. I'll just go ahead and get the marker and I just mark where the ASIS is and the pubis is, so the surgeon has that visually, depending on how well you know your surgeon. And then on the inside, sometimes I work with a newer surgeon, young in his career, and he wants me to, once we get docked up with the robot and he's on the console, he wants me to find the anterior superior iliac spine for him and kind of follow it down with my finger so he can see me pushing from the inside. And I, identify and mark that for him so he knows that's where he can safely start his dissection. They don't want to go lateral to that or superior to that. So just kind of those major landmarks that they're looking at and starting their dissection of that peritoneum. They're getting in those planes that are avascular. And if you're at a hospital where, residents are being trained and taught, you'll learn these things too. You hear how the surgeon is teaching the resident and what they're telling the residents to look out for, and you'll learn a lot as a first assistant. So I'll say that as a caveat to having residents, which we don't always love as first assistants. That is a perk of having residents, because you get to learn along with them a lot of these things. So do you have anything to add as far as the anatomical landmarks that we're looking at down there?
No, I think you pretty much covered it. One thing that the caveats that we want to mention for people who are maybe new or just coming into it, maybe new first assistants or new surgical techs, anybody who's listening that hasn't done these before, whether it's booked as a right or left inguinal hernia repair, know in the back of your mind it's always possibly bilateral. So you want to make sure, obviously, you're going to prep out both sides. And you'll see that once you've been doing this for a while and you know the anatomy and you know what an inguinal hernia looks like, intra-abdominally, you can spot it immediately. So that's a lot of times the first thing the surgeon will do. Now, I worked with one surgeon who would, as soon as he got in the abdomen and insufflated the abdomen, he would put his mesh and his needles in through the trocar, and then we dock the robot, and then he would go to the console and do his thing. That way there's no switching of anything. We only use 3 ports, which a lot of times is what people use for inguinal hernia repair. But just know that in the back of your mind. Always bring a right and left mesh in multiple sizes. And when we get into mesh, we'll talk about the different types. But yes, so that's one thing I would say. The critical anatomies, like you said, the ASIS, the pubic tubercle, Cooper's ligament, those kind of things. And yeah, I worked with a surgeon that would have me push on the ASIS, or he would have me push over where the direct hernia is to invert the sac so he could grab it, dissect the sac out, and then he would actually tack the sac to the pubic tubercle. I don't know why. He's the only person I've seen do that, but surgery, traveling around, I learned surgery is regional as well. People learn it one way and they continue to do it one way until they change for whatever reason. New data comes out, or they see something better, or another surgeon comes to work with their practice that does it a different way and they like it, so they change. But typical surgeons don't like to change only if it's a benefit to the patient or if it makes it faster and safer for the patient, then they change. But no, I think that's a great idea. We should always be aware of those things that they can change. And I'll include pictures of what a direct inguinal hernia looks like, indirect inguinal hernia looks like, what the triangle of pain looks like, what the triangle of doom looks like. We'll put all those pictures in here so you guys can see. But those are all in David Lourier's videos, which are another he does a great discussion of the anatomy down there, much better than Kelly and I could ever do.
Yeah.
So, probably consider.
Great. Yeah, that's a good resource, John. Thanks for doing that. Before we get into the mesh discussion, I do want to, I think this is a good place, and maybe I should have done it. We should have done it earlier, but talk about the draping and prepping of this surgeries.
No, it's
We know in an
a perfect
open,
place because we can talk
in
about
an, yeah,
open at the same time. The mesh is the same. It's just where it goes. So,
right, right. So in an open inguinal hernia, you obviously want to make sure that it's all our hair is shaved away. I like to get a wide, as most are, a wide area of drapage down there, but we're gonna be that incision's gonna be in an open repair. It's gonna be above you just said it, my brain's not working today.
above the inguinal ligament.
Ligament is gonna be somewhere in that area. So we do, in a male, we want to prep out the penis and scrotum. We wanna prep those out, and the way, just real quick, we're doing that is prepping all of that. When the penis and the scrotum are all prepped, the CST can come in with a towel, and then that lays flat under the scrotum, and then that's laid on top. So typically those are in an open repair, those are draped in the field, and then we kind of cover them with a towel maybe on top. Um, but we do that so that we can readily assess the position of the testicle and the scrotal sac. John and I discussed before we started recording, when we were just talking, and it's never, ever a bad idea to go ahead and do that in a robotic case as well. If you're doing a robotic or laparoscopic surgery for this procedure, never a bad idea. I mean, I don't think you can go wrong prepping the penis and scrotum. And even if you don't drape it in the field, if it's prepped in and it's sterile underneath the drape, which I know, listen, don't come at me. Some people are going to say, well, it's not sterile if the sterile drape's on top of it. If it's at least prepped in, if in a kind of an urgent, and I did have this happen not too terribly long ago, where the surgeon was on the console and wanted me I had to cut a slit in the drape and palpate the testicle for him and pull it down, kind of just to give him a visualization and make sure that he wasn't pulling pulling the testicle up into the field, because there was just a lot of tissue down there, and you can't see the testicle, for instance. So that was intraoperative. I had to do that. So it kind of always, when I have to do that during the surgery, and then I'm contaminating my glove, and you have to do all the things to correct that. You can't go wrong prepping all that in. So obviously the patients are supine, and yeah, getting all that prepped in is not a bad idea. But in an open, I would say it's pretty routine. You need to do it in repair.
That's a good point you bring up, and I think it's common now because the newer nurses and newer techs, and I'm not slamming anybody. This is not an insult. This is just a fact. If a lot of people have never seen an open gallbladder either. It's just the function of surgery, how it improves. Some people have never done or never seen an open inguinal hernia. Now, when I first started as a surgical tech back in 1992, all of the hernia repairs we did were open. So it was
Mhm.
common that you draped it out, and the nurse knew to wear a pair of sterile gloves, lift up the scrotum, hold the scrotum up, prep all underneath there. And then typically an abdominal prep was nipples to knees back then. They kind of
Right.
shortened it up a little bit. But yeah, so you want to prep under the testicles and scrotum. You want to prep the penis and testicles. And it's perfectly safe to do with that with betadine or chloroprep these days. It's fine. A 4% chloroprep is not going to hurt. You can do that, prep that, and then they either hold it up with their hand or with the prep stick and have the tech, just your drape towel and
Mhm.
fully opened, or maybe just a little cuff like you would normally do. And you want to put that under the scrotum and then let the scrotum, the testicle and penis lay on top of that, and then place another towel over that, like Kelly said. Now, I
Mhm.
would take issue with that. I would think that if you draped out normally like that on every robotic hernia repair, and then you had to reach for I still say it's okay to reach, cut a hole in the drape because it's
I did.
covered by
Yeah.
a towel and then
Correct.
it's prepped and then there's a towel underneath it. So I think you're
Mhm.
fine doing that, because I've had to do that before several times because they pull the testicle up into the inguinal canal. They can see the
Right.
epididymis and they want you to redeliver it. So
Right.
I
Right.
always try, and I don't always remember, but in the beginning when we're starting, when I'm shaving and stuff, I'll just look down and make a mental note, or I'll reach down and I'll feel to make sure that there are 2 testicles, because
Mhm.
that's something we check at the end. So I want to make sure it's there to begin with, because how do I know?
Yep. That's a great point.
He
Mhm.
might be a trior kid and then I miss it because now there's 2 there like they're supposed to, but maybe there was 3, or maybe he had
Mhm.
1 and now it might be a bigger issue. So I
Yeah,
just
that's a good
always do that.
point. Yeah.
But I suggest it, but as a traveler, I can only push that so far, because
Right.
if I get looks like deer in the headlights from people that are new nurses and new techs in the room, I don't want pushback. I'm not going to get, is it a big deal? No. I'll just suggest it. If they don't want to do it, then I'll move on. And I've been at
Mhm.
places where I've suggested, can you put a scrotal towel down because this is open? And they'll just stuff a towel between the legs like you would on, like, I don't know, a vaginal case, or like if you did a hemorrhoid repair that's in prone jackknife and you put that towel,
Mhm.
folded towel between
Mhm.
the legs to prevent rundown of prep or blood. They'll stuff it down there like that. And I'm like, it's not their fault. They've just never seen it before. They've never
Right.
done an open inguinal hernia repair. So, and it's not that common that we do them anymore. So,
So
yeah,
just
I
a
think
side
that's a
note
great
there, yeah,
point.
about the prepping. That is a little extra thing that we do during this specific hernia repair. That's kind of a little extra. Obviously, on females, we don't have to worry about that. But yeah, so that's a good just
Mhm.
a little side note. Now we're talking about the mesh. Now when we do the open, let's just start with the open because we haven't really talked about the
Mhm.
open repair coming down through those layers open. This is a lot different than the intraperitoneal approach.
Mhm.
We're coming down through the muscle layers, thin muscle layers, the external
Mhm.
oblique and the internal oblique, and the fascias that are associated with those muscles. And I think you have them listed pretty well there, John. You can
Mhm.
take us down from the skin on down and what we're going to find there if you want to.
Sure. Typically, when you start, you have skin, then you have the subcutaneous tissue, you have carpus, scarpus, and campus fascia. And then you move down, you have anterior rectus fascia. Then you have rectus abdominis muscle, posterior rectus fascia, extraperitoneal adipose or preperitoneal fat, so people call it, and then the peritoneum. So
Mhm.
those are the order,
Lots of
typically.
layers. Again, we don't have to, as first assistants, know every single little boundary. It's always good to know what your surgeons know. That's what they have to know these layers because these are their landmarks to find where
Mhm.
the hernia is occurring from the top side as we go down through there. So again, they're going to be pulling up that they identify, we know the spermatic cord. Typically, they will isolate that with a Penrose drain, wrap the Penrose around the spermatic or the cord structures, just to kind of isolate that. And you gently can then manipulate back and forth as
Mhm.
we try to peel the hernia sac away from there. A lot of times they'll use a Kittner. You can have DeBakey's and pick up very thin pieces of tissue to help the surgeon identify the layers and see the planes that he needs to get in. You can see the edge of that hernia sac pretty good sometimes when you can delineate that and just help him as you're assisting him with the visualization of that, helping him get down through those layers and really peeling that sac away so that it can just drop back down in through the ring. I mean, after he gets the hernia sac peeled away from the core structures, kind of just drop everything back down in there, and then we're going to put the mesh on. So sometimes it's the plug type mesh that looks like a badminton. I just call it looks like a badminton thing. I know a lot of surgeons have gotten away
Yes.
from this
Does.
because over time, I think I don't know, has studies revealed that patients
Mhm.
tend to have more problems with that plug and patch repair? You don't see it as much.
No, that's true. I think it's important that, like, so if we're talking about open hernia repairs, is in those layers I just mentioned, when you get to the transversalis fascia, you have the internal and external iliac ring, and that's
Mm,
kind of where the spermatic cord and its structures come out. So when we do an inguinal hernia, an open inguinal hernia repair, once we go through scarpus and Camper's fascia and get down to that transversalis, which that's where they open the external. They start from the external ring,
right.
open that with a pair of Metzenbaum scissors, and then you typically put a hemostat on either edge of that because that's what you're going to reapproximate at the end.
Mhm.
Then you start dissecting out the cord structures. That's put the Penrose down there. And then I always pick up DeBakey's and grab those cremasteric fibers to help find the sac. And I have a rule that I came up with many years ago that the first person to spot the sac is always wrong. Always. Because I would say, oh, there's the sac. And it was never the sac. And then the doctor would say, here's the. So that's what I've learned in my years of experience. Whoever spots the sac is wrong. You'll find it. You just have to keep digging around. And then typically some doctors will open the sac, push the cord contents back inside or any kind of peritoneal. There could be fat, could be omentum, could be intestine that comes through. They'll push that down in there and typically they'll ligate the sac high and then remove the sac.
Mhm.
And they'll do their repair, whether it's a Bassini repair, which is a tension-free repair with all tissue, or they'll do a Schuldeis or a Lichtenstein. The Lichtenstein is typical what they'll do, but they'll just lay a piece of mesh over the floor and then sew that to the conjoint tendon or the shelving edge of the pubic tubercle, Cooper's ligament, whatever you want to call it, and then the conjoint tendon on the other side. But you brought up a great point. There's a lot of different meshes you can use. I remember when that plug and patch method was really popular, but I think a lot of surgeons have seen the data that shows that there's a lot more nerve pain associated with that. I've seen those fail. I've seen some bad results with those in the past, but it's still a really good acceptable technique. I mean, things change
Mhm.
over time. Some surgeons adopt it, some don't. But
Right.
most people will either do the plug and patch or the onlay method. And then there's
Mhm.
that, I think what it's the PH proline hernia system, whatever that
Mhm.
PHS mesh that's got two pieces of mesh connected by a little tunnel of what
Yep.
I call it, and they'll put it under the transversalis fascia and over or under the floor to reinforce the floor anterior and posteriorly, and then
Right.
they'll close over the top of that. So
Yep.
typically, the way I've seen it done is when you suture the mesh to the Cooper's ligament, you run that. That's a running repair. And then they'll just put a few tacking stitches in the conjoint tendon or the transversus abdominis tendon right there, the aponeurosis that you'll see there. They'll just tack it
Mhm.
a few times. I've seen people staple it with a hernia stapler. There used to be a company called Auto Suture, and they used to make a laparoscopic hernia stapler that was long. But then they made gun type one that was kind of like their skin gun, their staple gun, and you could reload it and it had the same type of staples that you would use on the interior, but it was for the exterior. So in one surgeon I worked with would just staple that along the transversalis or the transversus abdominis aponeurosis.
Mm.
So
Mhm.
that's basically it. You want, but the key is tension free. It has to be tension free because if it's under tension, it's eventually going to fail. I
Right.
mean, when you stand up, a lot of times you can't even diagnose a hernia on CT scan because the patient's laying down. It takes that pressure of them standing up. And then
Mhm.
direct hernias are repaired in a similar fashion. And that's when the Schuldeis repair comes in. But we're not really going to get too far into it. We're only going to tell you that's where a Schuldeis repair happens. I'm not going to go
Right.
in on how to do it, how to
Look it
imbricate the
up.
floor. And right, plenty of great material out there.
Yeah.
But we're all trying to keep these a little on the shorter end. And we're tending to
Mhm.
more in depth we go, what's really you need to know. As
Right.
an assistant, you need to know the proper prep, drape, and all that. And always
Right.
drape out both sides when you're doing those. I
Absolutely.
we always do. Now you can cover the other side with a towel to keep everything isolated in one. But and I've worked with surgeons that whenever they put mesh in, they want to use IOBAN, which I think is a fantastic idea because then you
Mhm.
prevent any contamination because that's the thing. The key is using a macroporous mesh. That's what everybody uses now. Initially in Europe, they started with a microporous mesh, which was so it wouldn't even let water through it. You could pour water in it, it would not go through the mesh. But a lot of problems with that, infections and other things because it gets seeded when you drag it across the skin or the suture comes across the skin. I always try to hold the trailing edge of their suture up off of the skin. I never like it to touch the skin. But anyway, so it's a macroporous mesh that we use, and whether it's open or laparoscopic or robotic. So it's always it might be a different version of it, but it's the same type of mesh, and just where you place it is different on whether it's robotic or
Right. Because
so.
we know in the going on to the mesh that we use for the internal approach, um, in laparoscopic or robotic assisted is the anatomical shape of it. It's the contoured,
Mhm.
more contoured that they can place. And so that's where obviously the right or left comes in. You've got to know those are identifiable as a right side or a left side. So the surgeon is going to kind of fit that in there, dissect out that space, that pocket where the mesh can lay in there
Mhm.
against that hernia defect and not have any tissue entrapped under it, not be pulling or causing any tension on the surrounding tissue. So when they're doing that dissection, that's where they're trying to get that pocket big enough and assessing how big the hernia is based on the patient's size as well, internal size, whether it's going to be a large or extra large or the primary sizes that I see used with the contoured mesh. We know it's a polypropylene. It is the macroporous, like you just mentioned. So no need to dip this mesh or anything like that. They've made it to really fit easily down an 8 millimeter trocar, so you can pass that mesh in pretty easily. We know that M marked on those meshes mark the medial edge. So just paying attention to how you're putting it down the trocar and how you're passing
Mhm.
it to the surgeon, making sure the M is towards the midline of the body. But yeah, so they just line it up, kind of it's contoured, like I said, to kind of fit in that pocket and that inguinal space. And then a lot of surgeons will put a loose suture, medial, lateral, or both, just to kind of keep the mesh from slipping. So they do not tie this suture down. If you notice, they don't tie it tight. It's kind of an on purpose air knot. They
Mhm.
just don't want the mesh to slip. Now, previously, I know there is a Pro Grip. The Pro Grip mesh has those little, I call the little Velcro-y type on the side that goes against the tissue, and I think that is still being used. I've seen a lot of the surgeons that I've worked with recently have gotten away from that. I don't know if that mesh, if they were seeing a higher incidence of pain, of postoperative pain in patients, I
Mhm.
think. I do still think it's being used some, though. It hasn't gone out of usage, but that's something you may see, the listener, if you're listening. So it's the Pro Grip. So the idea there is you don't have to put any sutures, right? You don't have to tack it or suture it or to seal it in place for it not to slip. It's just kinda gonna grip the tissue. I guess, can it cause issues? I think, yes, it can, but on the other side, you don't have to put any additional material in there
Mhm.
to stabilize it. So, again, surgeon preference,
Mhm.
something for you to know as the first assistant, what meshes are available, what features and your surgeon likes, what they're looking for. Always talk to your mesh reps too, guys.
Yeah.
If you're listening, if you've got a mesh rep there, pick their brain, talk to them about their product. What are the good what are the properties of their mesh that they're selling that you'll gain a lot of information
Mhm.
from talking to your reps. So, and the tissue I mentioned, I've seen just very few surgeons, but I have worked with surgeons that do after they place that mesh. You kind of spray the Tisseal over the mesh, we all know that's a fibrin sealant glue type product, but I guess that holds it, holds the mesh in place
Mhm.
too. I haven't seen that used a lot. That's an expensive something to use, but you know, surgeons have their reasons, and what they think works and works well is what they're going to do for the patient.
Mhm.
So, have you seen anything else used to kind of hold those meshes in place?
There's a couple I've seen traveling in my years. I remember when everybody used ProGrip mesh, and now I
Mhm.
very rarely see anybody using it anymore for those
Right.
exact reasons I think that you described about the nerve pain, because you're taking that Velcro and you're unrolling it, and it's adhering to the tissue there, and if you skeletonize too much, then I think it could interfere. That's just my
Mm.
personal take on it, is the reason why, but
Mhm.
I've seen the Pro Grip, I've seen the Bard 3D Max, which I think is widely used almost everywhere, and then
Yeah.
something called Perfix or Prefix. I can't remember exactly what it was, but it was a mesh that has a cutout for the cord structures. So like a typical mesh you would see that you would do an open repair where you cut a slit to wrap around and reconstruct the internal ring. It has that already, and people just lay it on. It comes with a suture in there that you can tighten it down. Doesn't have a needle on it, but the surgeon I worked with would just pull that off and not use
Mm.
that and just lay it there. Now, typically,
Mhm.
it should be just an onlay. I've seen surgeons fix it. I've seen surgeons not fix it. But I think one thing you'll see them do is you'll see them pick up the peritoneum after they dissect it. You don't want to see that mesh move at all, because that
Mhm.
means you haven't dissected out far enough laterally or medially. Typically, you should dissect all the way laterally and all the way 2 centimeters past midline. If you're doing a right or a left, either way, you want to dissect long enough so when that peritoneum gets reapproximated and goes flat again, that doesn't roll up at the bottom in the inferior edge, because that'll lead to a recurrence, or it could lead to pain. They'll feel that mesh bulked up under there. So if
Right.
you see when a surgeon's done, they'll pick up on it, and it's called the pull sign or the drape sign. They'll pull it up to see if that mesh moves at all. And then some surgeons, like you said, will tack it in a few places with air knots. Some won't tack it at all. I've seen
Mhm.
surgeons, then they'll take your V-lock or your Stratafix and then close the peritoneum. I've
Mhm.
seen surgeons actually stick a needle in there or the suction tip and suck that air out so it lays flat again before
Right.
you desufflate. But I haven't seen that in a couple of places recently. But yep, then you'll take and I think it's good to mention some caveats right now. If you're doing the pro grip mesh, you want to roll it so the smooth side is in. So when they
Mhm.
place it and they unroll it, the Velcro unrolls against the patient. And like you said, that's perfectly with the macroporous 3D Max. You want to grab the M. If you're doing a right side, you want to put the M in first. If you're doing a left side, you put the side that doesn't say M in first. Never
Mhm.
understood that. Didn't really make
Well, it
sense to
depends
me.
on what
But when
side
you
you're
see
putting it
it,
in from too.
right, right, that's true too. Yeah. If I'm putting it in from the right and they need it for the left, I usually typically take it in the
Right.
opposite the M, because the way they grab it and place it, it's going to be right where it needs to be. And typically, if it's a right-handed surgeon, you're going to go from the port on the right side. Now, it depends if they dock from the left or the right, but I usually try to stand right by where they're using their scissors, because typically that's where they'll put their needle holder in, and that's where I'll put the mesh and needles down
Right.
through. The caveats with the needles, depending on the size of the needles, you may have to what I call canoe them open. That means you can ask your tech, they can do it. If they don't know how to do it, you can do it. You just take 2 needle holders and spread the radius of the needle open so it'll fit down the 8 millimeter
Mhm.
trocar. If they're using a 12, it doesn't matter. It'll fit down. The CT1
Right.
will fit down there perfectly. And then I would say if you're having trouble, especially with the 3D Max, now that it's a lot softer and macroporous, you could just grab the M and then push it down. It'll go in where you don't have to roll it up. You can just, it'll accordion on itself and go through the trocar just
Mhm.
fine. But if you're getting any kind of resistance or whatever, you could take that electroflux that they use and just stick your port cleaner in there that comes with the Clarify and just
Mhm.
like just grease
Yeah.
up the
Push it down
trocar.
there. Yeah.
Don't put a ton of it because you don't want to coat it, but it'll act as a lubricant. Some people wet the mesh to do that. You can do that too. But
Mhm.
I find that if you just take some of that electroflux or honey that they call it, you just put it on the valve and then, or you can just run it down
Mhm.
inside a little bit with the port cleaner. It'll shoot right down, but you want to be careful. Me personally, when I put the mesh in, I always use a blunted grasper, whether it's
Mhm.
locking or not, doesn't matter. But I don't want a Maryland, because God forbid that mesh all of a sudden gives. I don't want a pointy instrument going in that I can't control, because sometimes it'll get bound up and then it'll give. I do it really slowly and I fix it against my body and turn my body. So I let that all move at
Mhm.
once. So my hand doesn't go forward with just by trying to force it in that way. That's just my own personal
Right.
technique. And I like to use a laparoscopic needle holder to put the needles in, because nothing grabs it tighter than a needle holder.
Right.
Sometimes those Davis and Geck, they have those little scalloped edges. I find that it could fall right out. I've seen it has happened to me too many times. So I like, if I can get it, a laparoscopic needle holder. But
Right.
I will use a Maryland if I have to for the needles, but I'll never use it for the mesh ever.
Mm.
I don't want any. I've never seen it, but it's always been in the back of my mind. So that's how I put it in. And those are basically the caveats I have for a robotic inguinal hernia repair with
Yeah.
mesh, pretty much.
Yep. Yeah. So, yeah, and then when that case is over, when you've closed up and everything, if at the very end you do want to palpate the scrotum in a male, you wanna make
Mhm.
sure those testicles are down like we mentioned before. And, yeah, and that's it. So it's really one of the most common and most straightforward surgeries. You probably are in a good routine with your surgeon at this point. Always keeping up. Let's keep up with mesh evolution and new
Mhm.
I think we mentioned that it was polypropylene that these
Mhm.
inguinal meshes are made out of. Lightweight is better. So, yeah, I think we've covered everything, and, we've kept it to under an hour, which is definitely we were trying to
Barely.
stay at 45 minutes, guys, but, we're trying to be,
Mhm.
quick and to the point and really cover and be relevant to what you need to know on these. But we look forward to covering the rest of our hernias here
Mhm.
and bringing some good information to you and learning together on for an anatomy and procedural, all things hernia repair.
Yes, and just to add, some doctors may do a tap block at the beginning
Uh-huh.
of the
True.
surgery, or they may have you do it at the end while they're visually watching from
Yep.
the inside with the robotic camera. But
Yep.
either way, some doctors will close their port sites with the M-Close device, which we're hoping to bring you a educational spotlight on how to use that pretty soon. And we also have the conference in Atlanta coming up. We're currently recording this at the end of January, middle to end of
Yep.
January. So
Mhm.
should post fairly quickly, but that conference is coming up.
So we
And
got to
that's our
start announcing, reminding everybody about that. Yep.
exactly. And like Kelly said, it's good to keep up on the current trends of mesh and hernia repairs. And that's why going to conferences is so important. But if there's something that you guys have seen that we didn't cover, leave it in the comments. If you have a tip or trick that you think will help people, leave it in the comments.
Yep.
We'll more than share it on the next podcast episode, because like Kelly said, this will be an ongoing series. We plan to address each hernia, ventral, umbilical, and then open component separation, bigger stuff. But we'll still probably keep it on just the important stuff, not too far into the weeds, but because there's plenty of that information out there that you can find on your own if you're really interested in it. So, but we thank you for watching, and welcome to season 2, episode 1.
Yeah.
And don't forget to like, comment, and subscribe. If you can leave us a comment and subscribe, that'll really help us with the algorithm to get it out there. And if you're kind enough to go to Apple Podcasts and leave us a review, that would be even better. That would help us tremendously.
Yes.
Spread the word. Because the more popular it is, they put it in more algorithms and people get to see it that may
Right.
get
Yep.
some
It'll help the
benefit
show
from it.
grow, and you can
Mhm.
stay in the know listening to the Surgical Assistant podcast.
Yes. Thank you much for joining.
Thanks for listening today. We invite you to like and subscribe to this channel and leave a comment if you'd like. Feel free to look us up on Facebook at the Surgical Assistant Podcast or email us at thesurgicalassistantpodcast@gmail.com. Until next time. Content of this podcast is in no way intended for diagnosing or treating surgical conditions. No patient-specific information is shared. All HIPAA guidelines will be adhered to.